Welcome to AJP Audio for September 2023. I'm Aaron Van Dorn. Today on the podcast, I spoke with Dr. Antony Chum, Canada Research Chair in Population Health Data Science in the York University School of Kinesiology and Health Science in Toronto. Dr. Chum and colleagues investigated the disparities in suicide-related behavior between people of different sexual orientations and genders in a large population in the province of Ontario. Afterwards, we'll check back in with AJP Editor-in-Chief Dr. Ned Kalin on the rest of the September issue of the American Journal of Psychiatry. Dr. Chum, your study investigated the disparities in suicide-related behaviors across sexual orientations by gender in a large cohort of individuals in Ontario. Previous research into suicide-related behavior among sexual minority individuals has shown that gay and lesbian and bisexual individuals are at greater risk of suicide-related behavior than heterosexual individuals. But your study finds that much of the prior existing data and research into this area is lacking. Can you tell us about that?
Absolutely. So previous research has indicated that sexual minority individuals, such as gay, lesbian, and bisexual individuals, face increased risk of suicide-related behaviors, or SRB, compared to heterosexuals. However, our study aimed to address the gaps and limitations in the prior research. So many existing studies relied on self-reported data, or small sample size, or convenient samples, or cross-sectional design. So one of the issues, for example, with selection bias is the fact that previous studies have relied on survey-based research. So with a survey, those who have died by suicide or are too sick as a result of self-harm behaviors can't respond to a survey. Or convenient sampling, which is based on a community-based surveys, aren't really representative of the larger population. So these limitations have been addressed in our study. So our study sought to overcome these limitations using a large population-based cohort in Canada, linking it to health administrative databases to obtain the clinical outcomes that we're looking at. So this approach allowed us to provide more robust and representative estimates of disparities in suicide-related behaviors across sexual orientations.
And what did you find in your research?
So our study found that sexual minority individuals, specifically gay and lesbian and bisexual individuals, were a significantly higher risk of suicide-related behaviors compared to heterosexual individuals. So the crude incidence rates per 100,000 person years were 224 in heterosexual individuals, but we found that it was 665 in gay and lesbian individuals and 5,912 in bisexual individuals. So after adjusting for a number of factors like socioeconomic status, marital status, etc., we found that bisexual individuals were 3 times more likely to experience suicide-related behaviors, and gay and lesbian individuals were about 2 times more likely compared to heterosexual individuals. And these findings were robust after we controlled for a number of confounders.
You mentioned that your data was pulled from health administration data sets from the province of Ontario. Can you tell us something about the data that you drew from and how you hope to use it to correct some of the gaps you observed in previous research in this area?
Yeah, so our study drew from multiple cross-sectional cycles of the Canadian Community Health Survey, and we linked that to Health Administrative Database in Ontario. So these administrative databases include the Discharge Abstract Database, which contains all the hospitalizations, Ontario Mental Health Reporting Systems for any psychiatric inpatient and outpatient encounters. We have National Ambulatory Care Reporting System, or NACRS, which reports all the ED, emergency department visits. We have OHIP, which is Ontario Health Insurance Plan, which contains physician billing and physician diagnosis, and then ORGD, which are all the mortality records. So by linking all of this data to our population-based surveys, what we wanted to do was overcome the limitations in the previous research to provide a more comprehensive and population-wide view of all acute care visits, hospitalizations, and mortality related to suicide-related behaviors. So this approach allowed us to capture both fatal and non-fatal suicide-related behavior events and obtain more accurate estimates, reducing survivorship bias and also social desirability bias that's inherent in the surveys and self-reported data.
Your study was aiming to correct some of the limitations in previous research, but what were the limitations for your study?
So we do have unmeasured confounders. We were not through the health administrative database, even though we have longitudinal health records and health status, we don't have longitudinal employment status. So at the time of the survey, we might know these things at the time that they took the population-based survey, but in the longitudinal follow-up, we were not able to get the longitudinal employment status, housing status, and income. The health administration database also excludes people who move out of the province. The sample was not large enough to examine fatal events alone. Our sample didn't include people who indicated that they were non-binary gender. So, and other sexual orientations like asexual or queer were not asked about on the survey. So, another important dimension actually is that sexual orientation is complex, right? So, you've got attraction, behavior, and identity. And our question focused more on how people identify. So, whether they identify gay, lesbian, bisexual, but it didn't capture attraction and behaviors, right? So, that's an important aspect of sexual orientation that could have been missed.
Your study looked at longitudinal data over a long period of time, including a period that had a huge number of changes in the social status of LGBT people in North America. Did your study take into account the changes and the fact that data from earlier in the period might be skewed in a way on how people chose to identify themselves versus later on in this data set when the social mores had changed some?
Yeah. So the way that we did this study is there's certain things that we can control for and certain things we can't, right? So we did try to do a sensitivity analysis using the earlier parts of the data versus the later parts of the data, and the results were consistent. The other thing that we do is that even though people are interviewed at one point in time, we look at their entire life history as much as we can. So we take the time that they took their survey, let's say it was in the middle of the study period, we look backwards and we also look forward. People who come out later, for example, we're still able to use that information by going back in time by looking at their health records previously. Now, one thing to note is that more people are able to identify as LGBT, lesbian, gay, and bisexuals because of change in societal, pressures, things like that. And that's why I say one of our limitations is it's based on identity, so sexual orientation identity, rather than behaviors and attraction. So if we were to redo this study, being able to capture people's behaviors and attraction, it's likely the results might look a little bit different. And in fact, there's studies out there now saying that when behaviors and attraction and identity does not align, often people call that branched sexuality. So for someone who might identify as heterosexual, but who is a man who has sex with other men and are attracted to other men, that's a kind of branch sexuality that might have unique risk factors over and above those who identify as a gay man.
Mhm.
So further research, I think, is needed to understand these kinds of cases.
Are there immediate clinical implications for your study?
Yeah, so the findings highlight the need for increased education and awareness among mental health professionals about the elevated risk of suicide-related behaviors in gay, bisexual, and lesbian individuals. Many health professionals should be equipped with more knowledge to identify and address the unique risk factors and discrimination faced by sexual minorities. So these factors can range from individual level to societal level, right? So at the individual level, we have things like bullying at school, discrimination in the workplace, being targeted for LGB on social media, social isolation or rejection from family members. But at the societal level, it's also really important to look at some of these recent changes in the US, for example, such as the anti-drag bans, forcing students to come out to their parents. Like there's laws around that. There's also laws that ban the use of any words related to LGBTQ plus in schools. So in fact, the Human Rights Campaign recently declared a national state of emergency for LGBTQ plus Americans. More than 75 anti-LGBTQ plus bills have been signed into law just this year alone, which more than doubled last year's numbers, which is previously the worst year on record. So by understanding the whole spectrum of risk factors from individual to societal, clinicians can provide more support and interventions and treatments for individuals at risk of suicide-related behavior. So implementing educational initiatives that educates mental health professionals about these risk factors might help to reduce incidence of SRBs in sexual minority populations.
What's next for your research?
There might be ethnic differences in suicide-related behaviors in lesbian, gay, and bisexual groups, even though there are many health and social services that are targeted at LGBTQ plus individuals in Canada. Many of them don't consider cultural diversity. So, for example, PFLAG, which is Parents and Friends of Lesbians and Gays, traditionally have offered resources to help teens and youths and even adults come out and work with families and parents. But some of these resources aren't available to, say, East Asian and Chinese LGBTQ plus youths and their parents. What we want to do with this research is to understand some of these ethnic differences and within LGBTQ plus groups. Another project that recently was funded from our lab, we are looking at self-harm in trans and non-binary individuals. So understanding the impact of policies on gender-affirming care, on suicidality and self-harm behaviors in transgender population. So we are partnering with EGAL Canada and other community organizations to talk to trans folks about how their experience in getting gender-affirming care or not being able to get this care affected their well-being and self-harm ideation and behaviors. We also have quantitative components which tracks laws banning gender-affirming care or introducing them in different regions to understand its impact on suicide-related behaviors in trans and non-binary folks.
Dr. Chum, thank you for taking the time to speak with us today.
Thank you so much for your time.
Up next, Dr. Ned Kalin.